Great. Okay.
Okay. Good morning, everyone. Today, I would like to share a stroke case with you. It's a case about collateral failure. Before I start this topic, I would like to share something basic about the perfusion imaging. We all know that when the stroke patients come to our emergency department, we need to fastly diagnose if he has a severe stroke. So we would like to choose a faster way to do the imaging, and CT perfusion is very suitable because CT perfusion can show the perfusion deficit in stroke patients, and it's much faster than MR perfusion. So let's firstly look at how many perfusion parameters in CT perfusion. It mostly include 5 parameters, include mean transit time, time to peak, and time to maximum of the residue function, cerebral blood volume, and cerebral blood flow. So among these 5 parameters, there are 3 parameters very useful, and they can reflect something about the hemodynamics of cerebral blood flow. They are mean transit time, Tmax, and TTP. Firstly, let's see mean transit time, MTT. MTT is the average period of time that blood spends within the blood vessels in particular part of the brain. And MTT is measured in seconds, so do Tmax and TTP. In acute stroke imaging research, regions of abnormal MTT prolongation are sometimes described as representing tissue that is at high risk of infarction. And the Tmax perfusion parameter primarily reflects the bolus delay between the site of the atrial input function, EAF. Let's see what is EAF. So in this image, this is a reconstruction image from my STAR software. So there is a very, very small yellow square here. And beside that, there is a small red arrow, and this arrow points to the BA, basal artery. And this is a selected artery to generate arterial input function. So we can see there is a red circle, a curve here. So this is the AIF, and beside that, that is a blue curve, that is VOF, venous output function. And then at time to peak, that is TTP, is a perfusion parameter that theoretically could be superior to Tmax for assessment of critically hypoperfused tissue because it does not require deconvolution and therefore is not dependent on the EAF, but it also has some drawbacks. Just like it's not only delay sensitive, but also sensitive to arterial dispersion and tissue transit time. So TTP reflects the sum of these 3 effects. So after that, let's start this case. This is a very easy stroke case for diagnosis. This is a 61 years old male. His chief complaint is right limb weakness with weakness about 3 hours. And this patient had a sudden right limb weakness when he was walking. It's about 13 o'clock. And he was also found of weakness when he talked with his family members. And he had no dizziness or headache, no nausea or vomiting at that time. And he was rapidly transferred by an ambulance to our center. And all the symptoms did not improve during transfer. And he had hypertension, and this patient didn't take antihypertensive medicine regularly. And in the physical examination, I found he had dysarthria and right central facial and lingual paralysis and right limb muscle strength grade 4. So we count his needs score is 4. And the systematic physical examination were normal at the time. So let's see the baseline multimodal imaging. That is 2019, February 9th. And at the time, the brain non-contrast CT showed negative. There is no very obvious hypointensity. And the CTA and CTP are all very obvious that there is a left, the M1 segment severe stenosis in his left MCA. And the right image is a CTP raw image. No, not raw image. It's reconstructed, but it's not by the software. Outside, it's just from the Toshiba machine. This image, we can see that his left brain had a very severe TTP prolongation, the right part. And then we provide intravenous RTPA. So for this patient, he had a stroke onset at about 13 o'clock, and he arrived at our center at about 15:22. And then 30 minutes later, we finished the multimodal CT, and then at 54, we provided intravenous RTPA. So the DNT is about 32 minutes and ONT is 174 minutes. So for this patient, the speed is fast enough, I think. And the diagnosis for this patient is very clear. At that time, we think he had the left side acute ischemic stroke, and for the etiology, it might be a large artery atherosclerosis type. And because of his CTA, baseline CTA, we think that this part is it's not a new occlusion. It may be ICAS stenosis. So this is the second day MRI scanning. So we can see the scattered lesion distributed in the basal ganglia and watershed zone. But I found a very interesting thing for this patient. In his baseline CTP, his TTP in his left brain is prolonged, but his MTT, you can see that this part, the color is like blue. That means the MTT is very short. So the TTP and MTT are opposite, but for most stroke patients, TTP and MTT should be in the same way. If a stroke patient had a prolonged TTP, mostly in general, their MTT should also be prolonged, but for this patient, they are opposite. And I checked some references for articles to check why. Firstly, because we consider this patient was an ICAS patient, so he had a M1 segment stenosis maybe previously. So this time the stroke is about a collateral failure. And the MTT is always seen in AVM patients because prolonged TTP indicates increased upstream resistance. That means a more formed vascular nets. But for short MTT, that means increased downstream veins. That means although we have stagnation or obstruction when cerebral blood flow come into the brain. If you want to go across stagnation or the obstruction, it's very difficult. But because of the increased downstream veins and the blood go from the arteries to the veins becomes faster, so the MTT becomes short. But for this patient, he has no AVM. So we think it probably it reflects something about the venous outflow status. And after that, the second day, we found that the patients become getting worse. He has dysarthria and the right central facial and lingual paralysis persist, and the right limb muscle strength grade 2. At the beginning, the grade 4, but now grade 2, the knee score is increased. It's 8. And we fastly repeat the CT perfusion. Let's see, the TTP still increased in his left brain, but at this time, the MTT also increased. So if at the beginning, the MTT shortened, if we consider the shortened MTT is the increased downstream the veins, but the second day MTT prolonged, that means the transition of contrast from the arterial to the veins become slowed. So there might be the problem of the metabolism of cerebral blood flow, especially in the brain tissue level. So let's see the support from brain SWI. At the same day, the second day after the stroke onset. So this is his SWI, and we can see the medulla part has ipsilateral obvious brush sign. If we do stroke imaging research, we know that brush sign. That means it's like brush. So here you can see a green circle here, and within the circle we can see some straight vessels here. That is veins, medulla veins. And this very looks like a brush, so we call it brush sign. It always reflects the stagnant blood flow. And in this image, we can also see some vessels besides the cortex. So we don't know actually if they are collaterals, but we believe that is collaterals because at that time the contralateral part are very normal, but in the ipsilateral, they're very flush and very looks much more than the other side. And let's see a dynamic CTA. So from this dynamic CTA, it can also support a delayed venous outflow. Let's especially look at the superior middle cerebral venous. So at the beginning, when the contrast go into the artery, you can see at both sides, the contrast exists. And then it's 11 seconds. And then 2 seconds pass. So at this time, you can see there's a very slight signal here. That is the right side, at the contralateral side, the superior middle cerebral veins. That means the blood go across contralateral artery and then can be drained by the same side cerebral veins. But at this time, we can see that there is no veins here in the ipsilateral. So it delayed. And then 2 seconds passed. The ipsilateral veins still don't exist. And then we continue. So now it's 23.5 seconds. So compared with the previous seconds, it almost passed 7 to 8 seconds. The ipsilateral superior middle cerebral vein just exists. So there is a venous outflow delay. So at last, they both exist. And at the late venous phase, we can see that the contralateral part, the contralateral hemisphere, the veins become disappeared, but the ipsilateral part, hemisphere, the veins still here. So there's an obviously delayed venous outflow in this patient. So because of this, we know that there might be deterioration of this stroke patient, not only because of collateral failure, but always with delayed venous outflow and with a very deteriorated symptom for this patient. So we just provide infusion, a fluid infusion, and DLNBP, this medication. Maybe for Chinese, we're very familiar to this medicine, but we don't know if you have this medicine in USA. This medicine is used for promote the opening of collateral flow, and it is useful to protect the mitochondria. And this is his third day CT perfusion. At the beginning, I don't know why he had so many times CT perfusion, because in our routines, we only provide once or twice CT perfusion for stroke patients, because we want to compare the perfusion deficit, the change of perfusion deficit in this patient during the hospitalization. But for this patient, he had the change of symptoms, so maybe we provide more times for this patient of CT perfusion tests. And this is his third time CT perfusion. Unfortunately, we see although the TTP still increased, but MTT seemed maintained, not very obvious change. So this is the second phase, and so I bring the 3 times CTP together. And at the first day, the February the 9th, that's his CTA, the first CTA, and the right part is his baseline CT perfusion. We can see a delayed TTP, but shortened MTT. And CPF seemed slightly increased, but the CBV seemed normal and very equal between the two sides. And then we know that the onset of the stroke may be because of the collateral failure, because this patient was an ICUS patient. And not only the collateral failure, but also with the abnormality of cerebral venous drainage. Because of this, we can see the change of perfusion deficit in his second CT perfusion. In his February 10th CT perfusion, the TTP still increased, but the MTT also increased. And the CPF seemed slightly decreased, but fortunately CBV is still maintained, because CBV is a formula very related to the value of CPF and MTT. And after the infusion of fluid and the provision of DLNBP, this medicine, the perfusion seems maintained. At February the 12th, the TTP, although still increased, but the MTT seemed maintained. You can see that the both parts MTT, the both hemispheres MTT seemed equal, and the CPF equal and CPV equal. And from the baseline to the third day's CTA, they look same. So there is no obvious change of the stenosis, but the perfusion changed. So after this case, let's discuss something about the collateral flow. Let's firstly see how to classify the collateral flow. Cerebral arterial circulation, we always divide it into the extracranial arterial collateral circulation and intracranial arterial collateral circulation. And because of Willis circle is very obvious and easy to diagnose, in recent researches in about the 20 years, in the recent 20 years, we always use imaging to test the collaterals we cannot see very clearly because it's very mysterious. It's like a mystery. We don't know very much about the leptomeningeal, so we focus on the studies of the leptomeningeal. And the leptomeningeal collaterals, actually, if we are collateral, well, if we are leptomeningeal meningeal collaterals, we are antegrade flow. But for the brain tissue, the collaterals are retrograde flow. So there is a delay of the collateral flow, because if they are normal blood flow, they go for the anterior circulation, the blood flow go into the middle cerebral artery, and the blood flow just go across them and into the brain tissue. They're very fast. But if the occlusion, there is occlusion in the middle cerebral artery, so they need, the brain tissue need the blood supply from the PCA or ACA. So the blood flow need to transfer from these two arteries. They become much slower than the directly supply from MCA. And the delay of the blood flow generates two very important imaging markers for our stroke research. They are ischemic core and penumbras. Ischemic core, that means this tissue cannot be solved from the reperfusion treatment. But penumbra, they are the brain tissues can be saved after effective reperfusion therapies. Yes. If we cannot save the ischemic core, if we cannot save the penumbra in time, so some part of the penumbras may become ischemic core. And let's see, what is collateral failure? Many colleagues may be not very familiar to this definition. So collateral failure, I think it is firstly published by Dr. Campbell Bruce, published in BFM. And this is an example of a patient with collateral failure. Let's see. As a baseline, the distal right internal carotid artery is occluded, but the DSA subtracted, DSA perfusion magnetic resonance imaging. Actually, this imaging is at PWI. From the PWI, they generated like DSA. According to the DSA ways, they reconstructed PWI to generate this image. So from this image, we can see excellent collateral flow via the sucrose of Willis, and this corresponds to a large mismatch between the diffusion lesion and Tmax lesion volume with relatively mild Tmax severity and preserved CPV. So here, you can see that the DWI is almost inactive, and the Tmax, there is a very obvious like a perfusion deficit, and the CPV is still very normal. However, by day 4, there is no longer significant flow within these collateral vessels. So we can see that this is a 0 second, but to the 20 seconds, this part has significant perfusion deficit. There is no perfusion. So it also accompanied by major infarct growth. So here the DWI a large area of infarction, and the Tmax showed very significant increase of Tmax. The colors become red, and the CBV, we can see that there is a reduction in cerebral blood volume. So, so the outcome of the prognosis for the collateral is very significant. But today we not only talk about the collateral we also need to know the relation about the venous drainage and the collateral flow. Actually, in recent studies, many studies found that the favorable venous outflow profiles correlates with favorable tissue level collaterals, liquid tissue level collaterals. Actually, it depends on how they diagnose or how they observe collaterals. Many ways to observe collaterals actually by CTP, CTA some ways, or the golden standard by PSA. So how the collateral and how the collateral correlates with venous drainage abnormality. From my point of view, after the acute cerebral artery occlusion, with the suction of negative pressure, the collateral flow comes to decrease the blood flow. However, at the time of ischemia, a prolonged venous thrombosis generate and occlude the outflow pathway. Therefore, the collateral flow was unable to penetrate into the ischemic brain tissue with the driven of negative pressure, leading to the enlargement of brain infarction. In brief, so there is a network between the cerebral artery and cerebral veins. Although the perfusion support from the collateral flow can compensate the perfusion deficit, but actually the brain perfusion not only depends on the arterial flow, it also depends on how the arterial flow go out of the brain, that is cerebral venous system. So if there is a stagnation of cerebral veins, it also can affect the supply of collateral flow. So from this image, you can see that there is a clot here. It occluded the cerebral vessels. And at the beginning, the collateral flow may go the other way into the brain to bring blood flow to the brain tissue. And if there is a normal venous outflow, so this brain tissue can be well provided by the blood flow, the blood flow. But if maybe many minutes passed, because from the animal experience, animal experience, we can see that after 5 minutes, even after 5 minutes of stroke happens after ischemia, there is venous thrombosis generated. So if the venous was occluded, the collateral flow can be significantly decreased because it cannot be drained by the related veins. So not only the venous outflow decreased, but also the collateral flow decreased, and it finally caused a collateral failure. So this is the relation between the collateral failure and venous drainage abnormality. And for this patient, let's see the follow-up of this patient. The right limb weakness was not improved after the RTPA at the beginning, but the symptom was not improved 4 days later. Was improved 4 days later after the hospitalization. And his physical examination at discharge he still had dysuria and right central facial and lingual paralysis. But fortunately, his right limb muscle strength was improved to grade 5. So the fine lateness score at discharge was 2. Some tips for you from this patient. So I think there is a close relationship between the collateral flows and venous outflow. And for this patient, because he had experienced a significant change of the perfusion deficit, so we need to evaluate the perfusion status dynamically. It seems very useful, especially to prevent this, the deterioration of the brain perfusion, or what I call collateral failure. But unfortunately for this patient, we didn't do dynamic observation of his cerebral venous system. We only did once at the second day after his admission. So that's a limitation. Thank you. I finished. Dr. Stein.